everybody. Thank you for showing up early this morning. Welcome to the 2024 MEDX Primary Care Senior Conference in conjunction with Pennsylvania. It's exciting to bring these entities together for what's going to be an amazing conference over these next 2 days. And on behalf of both, I just want to welcome and thank you for joining us. It's great to be here, and we welcome everybody virtually too from around the country and even some folks internationally. I'm going to be your moderator for the day. My name is Tracy Paparo. I'm a PA practicing in Central Jersey. I do inpatient palliative and supportive services. Just going to share some relatively good information here with you from our sponsors and things. Here's the goal, target audience, and learning objectives for today's program. And we have lots of esteemed faculty with us. They're very renowned for their own, specialties, and we're super happy to have them here sharing all of their knowledge with us, their experience, and their expertise. We really appreciate them coming here to share this with us today. So we want you to download the slides. So don't get nervous if you see something that you want to remember. We want you to download them for your own reference. And we're also going to thank our commercial supporters. And we are going to talk about the iPads that are on your table. This is super fun, and don't be afraid of technology. It's going to allow you to answer the audience response questions. So you can also submit questions to the faculty, connect to other valuable conference resources, and we're going to watch a short video to show you how to use the iPads, because I know we all get intimidated for those of you that are in person. And we do encourage you, please use them throughout the educational sessions, because it's really going to help just enhance your overall learning experience.
Hello and welcome to this Clinical Care Options program. Please take a moment to familiarize yourself with the iPad that has been provided to you. The iPad provides a unique way to engage with the program and participate in the polling questions. Please take a moment to log into the iPad to participate with the program. Once logged in, you will be able to answer the polling questions, submit a question to the panel, save a slide, take a note on a slide, rate the slides. To vote and engage with the poll is quite simple. The poll question will automatically appear on your screen. Simply tap on the answer you would like to select. If you would like to submit a question to the panel, click on Ask a Question at the bottom of your screen. Type in your question and then click Submit. Due to time constraints, not all questions will be addressed during the event. To take a text note or to draw a note, simply create your text note or make your drawing and tap Submit. The notes you take will be emailed to you after the event if you provided an email address. Other functionality available with your iPad ability to rate and save shortly.
So another great reminder, we're all here to learn, but also get valuable credit for spending our time here on a Friday. So just remember that after the presentations, you can complete the evaluation form to claim your credit. We're going to move right into our first presentation here, and our first accredited educational session is going to be given to us by Chelsea Monroe, who will be presenting Shedding Light on PTSD in the Community, Guideline-Based Care for Primary Providers, which is part of the overall program of clinical excellence in PTSD care, aligning real-world practice to guidelines. Chelsea is an adjunct faculty at University of Colorado Anschutz Medical Campus College of Nursing in Englewood, Colorado. We're super happy to have her here with us today.
Thanks, guys. And would you guys mind setting the timer for us? Because I can't talk in 30 minutes because I'm going to go on and on and on. You guys won't want me to talk all day long if I don't have an accurate timer here. Thank you. Appreciate it. So thank you for the introduction. My name's Chelsea Monroe, and I'm so excited to be here with you all today and to start out your conference talking about something that maybe you guys aren't as familiar encountering or really don't want to encounter on a daily basis. How many of us in primary care are like, oh, it's psych. I don't want this to be my first topic of the conference. But I hope to impart on you some great tools to utilize with clients because trauma is everywhere. I know that I'm sure all of us have heard many psychiatric topics before, and it's maybe not our favorite thing to encounter in a 15-minute med follow-up in primary care, right? So I hope to give you some tools to use so that you're not having to take on that burden, but really help the clients get what they need. So here are my disclosures to use. And before we get started, I'd love to just hear a little bit about where we're starting out with in terms of confidence in prescribing or treating PTSD in our population. So let's do some pre-test questions. I know it's early in the morning. If you can press those buttons on your iPads, and for those of you at home, please feel free to follow along as well, and you can vote too. So here's your first pre-test question. Which of the following patients would be appropriate for an assessment with a primary care PTSD screen? So it's a heads up of something we'll be talking about today. It's a PC-PTSD screen. So is this any patient who's experienced a traumatic event, either involving a threat or actual harm to themselves? That's A. B is any patient who has been physically present or witness to a traumatic event, whether that threat was to themselves or others. C is any patient who's experienced or witnessed a traumatic event to themselves or others, and including learning of a traumatic event involving the harm of a loved one. And D, every single patient should undergo a comprehensive screening regardless of whether or not they self-report any sort of trauma or exhibit obvious signs of distress. So go ahead and punch in those answers on your iPad if you can, and we'll do a post-test at the end. Okay, wonderful, thank you. All right. Pretest 2, which antidepressants are recommended to treat PTSD based on our 2023 VA or DoD guidelines? So these are the newest guidelines that have come out. Is it A, sertraline, fluoxetine, or escitalopram? B, sertraline, paroxetine, or mirtazapine? C, sertraline, paroxetine, or venlafaxine? Or D, sertraline, escitalopram, or venlafaxine? You know you got one of these right, it's sertraline, okay? So pick your favorite option here. I will tell you I use all of these. You're going to have a whole tool bag that you can use for PTSD, but which are the ones that are most evidence-based? All right. Okay, we have folks saying sertraline, escitalopram, venlafaxine. Close second is A. Okay, let's go to the next one. Pretest question 3, which of the following individuals who have reported experiencing a trauma would be a priority for a referral to someone like me, a psychiatric specialist? So A, an individual who has anxiety, is coping well with their stress through some lifestyle changes, support from friends and family. B, a person who has a recent diagnosis of PTSD, has only had a few therapy sessions in, but is showing some improvement in managing their symptoms. C, an individual experiencing persistent PTSD symptoms that are causing some impairment in their daily functioning and haven't responded to some initial treatment efforts. And D, a person with a long history of depression who's currently stable on some medication and participating in regular therapy sessions. Thank you for the music this morning. All right, folks are saying C. Perfect. Okay, I think we will get started here. So here's our learning objectives for this morning. What I want to share with you is some more information about screening for PTSD. We'll give you some evidence-based outcome treatments so you can get an idea of like how we're dealing with this in psychiatry, maybe some of the things that you want to use in your own primary care practice. And then how do you want to refer to a specialist? What are the guidelines? What are the recommendations? When is it time to refer to the next level specialist? Because I'm guessing you all are utilizing your skills, your psychiatry skills, in almost every encounter. And you are taking on probably the initial burden of psychiatry in the United States. So thank you very much for that. But when is it time to then escalate things to the next level specialist? So when we talk about trauma and PTSD and that impact and prevalence, this is one of the areas that I feel is my specialty because I got into this field wanting to treat all kinds of different mental health disorders. But what I found was that trauma was pretty pervasive across all kinds of mental health disorders and across all different patient populations. So in my practice in Inglewood, I have an outpatient group practice. And it's technically a private practice, but my specialty and my background has been treating underserved patient populations. So I kind of have it set up as a community mental health center. And on one side of the practice, I do ketamine-assisted psychotherapy that charges cash for those services, usually very different patient population, people who are capable and able to pay for those services. And on the other end, on the medication management side, I see people coming out of prison. And that's one of my favorite patient populations to work with. And across those spectrums, people coming in for ketamine for their trauma and people coming in for maybe medication management for their trauma out of prison, it looks so similar across these patient spectrums, okay? So it does not discriminate. And I'm guessing that if you showed up here as the first talk of the day around psychiatry topics, chances are you're maybe either interested in mental health yourself, you've experienced some sort of mental health trauma yourself, or you know someone who has. You know the impact that that can make on either your client, yourself, your loved one. We've all experienced some sort of trauma or stress in our life, and it'll show up in everyone, right? So whether or not that goes into PTSD, that's a whole other topic, right? So this is our global breakdown across the world of trauma and stress-related problems and symptoms. So 70% of individuals worldwide have had at least one traumatic event in their lifetime. And that's subjective. What is trauma to me versus what is trauma to your friend or loved one? This is going to be, a little bit subjective here. But notice United States versus other countries. We're carrying a lot of high symptoms of trauma and stress. I wonder why that is. There's a lot of cultural reasons that go into this, but I think it's fascinating that, the United States, as many resources as we have compared to some other countries, we carry a huge amount of stress and trauma-related symptoms. But we all can be exposed to trauma at one point in time. Who gets PTSD versus experiencing a traumatic event and eventually recovering from it, right? So these are incidences of specific larger traumas, what we call sometimes big T's, very serious incidents or injuries that people can either witness or experience themselves. Not everyone who has these will develop into some sort of a PTSD reaction. What is PTSD in the first place? So it's a conglomerate of symptoms that occur usually at least 1 month or persisting beyond a month after the exposure to that event. But the exposure has changed over the years, and what we use as the DSM for our diagnostic book. So the exposure can be an actual or threatened death, serious injury, or violence in some sort of way, either to yourself, to someone else, and you're learning of it, like you're witnessing the event. And so it doesn't have to be directly onto you. You can even learn about what happened through a close family member or friend, and that can impact you and create PTSD. So experiencing these events, the aversive details to it, and then over the course of that month, you may experience as a natural cause of that event, maybe some fear response, right? Maybe some of these symptoms over here on the right, that's a normal acute stress reaction. Our bodies get turned into this fight or flight type of experience. And over the course of that trauma or anxiety that's coming on as a result of that trauma, you may have this fight or flight kind of kick in. What happens with PTSD is that it chronically kicks in. Okay, so this chronic nature going on longer for a month kind of persists. And the symptoms that you may experience, anything from intrusive thoughts, thinking about it all the time, paranoia around whether or not this will happen again, nightmares, flashbacks, mood instability, so irritability, depression, anxiety as a result of that. It's really common for people to not recall certain events of the trauma. That's part of that protective mechanism within our brain of almost dissociating from that just as a protective way. And so you may not have all of the actual factual events or details leading up from that trauma. And as a result, then you may have difficulty sleeping, irritability and mood dysregulation, self-destructive behavior. So this is from a single event, right? Single event. But why do some people get this and others don't? And you can compare this side by side with individuals who have maybe a few traumas in their lifetime versus individuals who've had repeated traumas in their lifetime. Why do some people get this kind of chronic fight or flight response and others don't? Well, part of this is related to our pre-existing environment and genetics. And we'll talk a little bit about transgenerational trauma here in a second, but our environment really can kind of lay the foundation as to what our response will be going forward. So if you experience a trauma, your body may go into this fight or flight response. And so that body's regulation, what we do as a homeoadaptive response, is kicking in a sympathetic nervous response when we need it, because that's what's going to get us out of danger. What happens is you learn that fear from the traumatic event, and you can consolidate that, and you either repair that consolidation in your memory and back to normal. So think of in the caveman times, right? This is this normal response that showed up. Human sees a huge threat, maybe something that could eat them, and they go into fight or flight response. They get out of danger, and that response comes back down. That's what we're supposed to do. If we have a foundation of genetic encoding and not response, that kicks back down, and we go back to normal. Those who get PTSD, it stays on. So one traumatic event that happens, let's say a serious accident or something, that response can kick on and off, and that simple PTSD can still be prevalent throughout someone's lifetime. But what about the clients and our patients in our care where that trauma started really, really young, and it's repeated over and over again? That's the majority of what I see in psychiatry is this kind of complex trauma nature where it starts out as developmental trauma. And then we have these bigger issues that come up like an accident or some sort of large event. But adverse childhood events and development really lay the foundation for someone's environment and their ability to recover from traumas. And in and of itself can be a trauma. So 1 in 6 adults have an ACE at least 4 or more screening. So just a reminder what the ACEs is, it was a foundational study done with over 20,000 people in the 90s, and they really collected what were some adverse childhood events that someone could have experienced, whether it be abuse, neglect, emotional things, witnessing violence in the home. Now it's been updated to things like experiencing poverty. So you can collect this data and information, and what it showed was that more likely if you have increased ACEs or adverse childhood events, you are more likely to have comorbid medical conditions and increased likelihood of early death. So 1 in 6 adults have at least 4 of these. Guess what? We as healthcare professionals, we have more. We're prone to have more ACEs in our lifetime being a healthcare professional than the average person. So something to consider as you're seeing your clients, viewing them from the whole picture here. This even goes beyond just being born and having early childhood events. This can start out very early prenatally. So think of mom and her lifetime experiences that she's had. As she's pregnant, she may be going through stress, poverty, relationship issues, whatever the course of her pregnancy may be. Her increased cortisol to then affect the placenta, and that's going to lay down the nervous system of that child, of that offspring. And so this can start even before a child is really born. That limbic system or that fight or flight response is going to already be activated potentially. So if whatever's mom is experiencing, we can assume that can get into the genes and encode that child. Now, then the child is born, and then they have their own experiences developmentally. So maybe there's traumatic experiences and there's difficulty regulating as a result of that. And that's because of that nervous system being primed for difficulty to regulate emotions. So it can definitely affect the development and sense of self that you may have, but then those individuals who grow up to be adults are more prone to actual having PTSD. They may unintentionally bring out these negative behaviors to others and feel emotionally dysregulated. And so this is where we start seeing comorbid medical conditions as a result of their inability for their nervous system to regulate. And then they show up in your offices, right? Complaining of what? Maybe anxiety, depression, insomnia, a whole 9 yards. So if we're not thinking of what's maybe underneath the root of some of these symptoms, we may be missing some of that trauma response. So this is a study showing actual Holocaust survivors and their offspring, their children, descendants were to have mood, anxiety disorders, and PTSD just from collecting their genetics and looking at the response from their parents. So there's simple PTSD in the DSM. And in the field of mental health, we're now kind of expanding out to an idea that's not in the DSM, and that is complex PTSD. So complex PTSD is an ICD-11 diagnosis, but it is not technically a DSM diagnosis. And that there's some dissension in our field around how do we treat this. But these are the clients that are showing up in your offices saying meds aren't working, multiple medical comorbidities, okay? And they're wanting medication after medication, nothing's working. And it's really common for people with this complex PTSD for meds to not really work as well because, again, think of that prenatal exposure to stress. Their nervous system is gonna be a little bit different than the average person's nervous system, okay? So that inner world that's happening within all of us when we're dealing with stress, for someone who's had lots of adverse childhood events, maybe prenatal exposure to that increased sympathetic nervous system response, that may manifest itself in some medical conditions. So it may be common to see physical symptoms of fibromyalgia, fatigue, irritable bowel syndrome, lots of headaches, migraines, even autoimmune diseases. Does this look like anyone in your practice? Anyone? This is maybe that kind of complex client that's coming in frequently and nothing's really working and they've got tons of stuff going on. So we'll talk about what to do with them today before we leave. But this kind of patient presentation is actually fairly common in outpatient mental health. And in my area, this can be seen up to 36% of the time in outpatient psychiatry. And you will see a difference in how PTSD versus complex PTSD shows up. So complex PTSD is like lots of emotional dysregulation and a fractured sense of self. So it's no longer this one traumatic event that I've experienced and I'm struggling with the reactions from that event and that has changed me for the rest of my life. This is, I've never really experienced a normal homeoadaptive response. I've experienced lots of adverse childhood events, developmental traumas. I then have traumas that kind of I seek out because that's what my nervous system is wanting in order to feel regulated. And then really easily overwhelmed nervous system, sometimes living in that fight or flight a lot, so maybe increased paranoia. That can look like psychotic symptoms, right? So it can be easily confused. We may have lots and lots of insomnia and sleep issues. And that's oftentimes when I'm seeing a client for the first time in psychiatry, their primary complaint that they're seeing me for is some sort of insomnia. So I'm peeling back the layers of what's happening with their insomnia and their other symptoms. And you may just see that this all kind of fits into one big picture of potentially complex PTSD. But how does this affect primary care? How many of these things on this slide pertain to you in primary care? Quite a few. This is going to impact your practice and how you're seeing your clients on a daily basis. And on top of it, the burden, the economic burden, even in the United States, is huge. Absenteeism goes up, medical comorbidities goes up, healthcare costs go up. So we have the ability to influence how someone gets care for this condition because no surprise, if you've experienced trauma a lot, there's a stigma with getting care. There's a stigma anyways in mental health of actually getting the care that you need. So having something like a PTSD or trauma response is even more at times stigmatizing. It's often misunderstood. People aren't seeing the big picture. And think of the people who have these repeated traumas, because their nervous system is needing that stimulation, it's almost like it's seeking out more chaos and trauma to regulate. And so oftentimes people think, oh, you're choosing to put yourself in this situation. You have a repeated history of being in domestic violence situations. You like toxic relationships. Right? So it's not always a conscious thing. The body just likes to seek out what it knows. But we as healthcare providers need to be able to have the conversation and understand this well, but also provide a welcoming environment to talk about these things. And it doesn't mean we have to talk all in depth about somebody's trauma, but to even understand, maybe recognize that this conglomerate of symptoms are trauma response. You know, substance abuse, depression, anxiety, control, kind of perfectionism, those are all ways in which we deal with our issues. So seeing the bigger picture here, I think, is important to not discriminate. And in fact, only a half of patients with PTSD actually receive treatment. 29% then even go on to get specialized mental health treatment. So the majority of those folks are seeing primary care. So we need to identify those who are early at risk for some sort of trauma exposure and then give increased access. Now, we can't fix all of our systematic issues within healthcare, right? But you have the power to influence whether or not someone feels comfortable to access care. So I really encourage all of us to look at our own trauma history, because remember, we all have higher ACEs than sometimes our patients do. So what does our own trauma history look like? Are we accessing our own mental health care? Does that prevent us from then talking with our clients about it? And know that this is going to be a relapse and remitting type of course. So this can be hard to treat long-term with someone. So what is the role for you guys all in PTSD care, screening, and diagnosis? Now here's one screener that you can use that's simple, it's free to access. It's called the PC-PTSD-5. And this is one screener that's looking at larger traumas. So these larger events, maybe a single PTSD that may be happening within a client. And it's asking if they've had any of these serious events. So if they say yes, it gives you the opportunity to then have more discussion. Usually using a screener as opposed to saying, tell me all your trauma you've ever had in your life. Nobody's going to open up to you if you're asking those questions. But if you do give a screener, it gives them a welcoming environment to rate and perhaps talk about it when they're open and feeling comfortable. Now, in primary care, the scores greater than 2 can warrant further assessment or further discussion. Okay. This is the primary PTSD screen. Again, looking at symptoms. You can also pair it with those actual events. And if we think that people aren't open to taking these screeners, this shows you that they are. Most people are actually pretty comfortable getting a piece of paper or doing some sort of online assessment personally within themselves, as opposed to having the direct conversation with their provider. It really opens up the dialogue by taking a screener. So most of the time, these clients, at least in VA primary care clinics, were comfortable taking the screener. I like the ACEs. I think it gives me a good picture of what I'm working with someone. So the more I know about their developmental trauma, the more I can understand their symptoms and kind of normalize and put in my mind, what are my next steps for treatment? So the ACEs is another great tool that's free. It was updated recently, so it includes some other things like poverty and where access to healthy foods, those sort of things that we may not think of that is a particular big trauma that someone experiences, but some information to help you understand what was going on in the family as someone was growing up. And then this is what we use in psychiatry most often. It's the PCL-5. This is a little bit of a longer screener, as the other PTSD screener that I gave you was about 6 to 10 questions. This is slightly longer, but it gives you an idea of symptoms that they are experiencing within PTSD, so you can get an idea of what you want to target or treat. Because that's all you're doing with PTSD. There's no guideline saying, here's exactly how to treat every single PTSD, and there's an algorithm and a treatment regimen that's going to cure it, just like, let's say, diabetes, right? Unfortunately, in mental health, we have conditions that are very complex, and people and humans are complex with their heterogeneity of the disease. And so you're going to be treating symptoms as they come up. So you want to know, as someone's doing a screening, what symptoms are the most prominent. And then you can have a discussion around what matters more to you to treat. Maybe it is nightmares, or maybe it's just anxiety. So it gives you a good starting approach here. So we want to be non-judgmental, be aware of your own bias and stigma, and using open-ended questions really elicits further response. Now you can do that in a 15-minute appointment, right? I do 15-minute appointments, and I do this. In fact, to the point where I've had clients say, yeah, you're my therapist. And I'm like, I am not your therapist. We're doing 15-minute med checks, sir. So you can really elicit some therapeutic rapport where you're using open-ended questions to elicit some more response and have a conversation, and really providing some sort of care and concern is what most people want. They want a little bit of validation and understanding right? So you can use the DSM, and the gold standard is using the PTSD scale, the CAPS-5, to diagnose some PTSD. But really having that screening to allow for open conversation is great. But as I mentioned, it's difficult to actually assess because every patient, even though I see trauma across the board in all kinds of people, we all as humans have experienced some sort of trauma. PTSD may show up differently for each person. So you may have someone with extreme nightmares, but everything else is fine. And then you have someone else that has never had nightmares in their life and lots of other symptoms that are overlapping. And this can look like bipolar disorder, can look like schizophrenia at times with severe complex PTSD. So there's some limitations here in how our DSM has categorized things. And we're going, hopefully, to a realm with the DSM where there's things more on a spectrum and it recognizes some more developmentally sensitive traumas. But right now, it's only focused on this one single trauma that you've experienced. So there's some differing opinions on how to treat this, but really we want to look at what the chief complaint is and look at the underlying root cause. And that will help you identify where you want to go for PTSD. When it comes to referring, so you have the ability to treat these symptoms. So if we think of someone with PTSD and they're experiencing depression and anxiety, you're going to treat the depression and anxiety. They're having insomnia symptoms, you're going to treat the insomnia. So you're really just treating the underlying symptoms. But what we want to do is encourage them to get the right type of therapy. It's really, really hard to find good therapists out there that are trauma focused, not only trauma informed, but to do some of that deeper trauma-based therapies that clients need. So when you're in that sympathetic nervous response all the time, your frontal lobe is offline. You can't access some of the things that maybe a client with depression and traditional depression and anxiety could access with CBT. This now we're changing our paradigm here for treating trauma and recognizing that it's stored in the body so much that if we can't access our frontal lobe, we need to flip it and we need to go treat from the bottom up. So rather top down with it, which is a CBT type of approach, using our thinking brain to help us rationalize and combat some of those irrational thoughts, we won't have access to that. So from the bottom up is working with the limbic system, feeling safe in our body, having some grounding techniques, being able to recognize when we're going into fight or flight, and being able to come out of that. When you can establish safety in that way, then you can slowly work up to more of a CBT type of approach. But most of the clients with trauma can't necessarily access that right away. And that's where we use medications as a tool to kind of balance that response. So my goal in treating trauma is to not over-medicate, because I'm going to shut down everything emotionally and prevent them from actually experiencing those physical sensations that we're wanting to have them gradually experience. And I don't want to under-medicate, because then someone's in that chronic fight or flight, that sympathetic nervous response, and we just can't access anything anyways, and we're feeling like we're in danger. So medication therapy is used strategically to find that sweet spot. And you may be treating symptoms and reactions as opposed to global things that we can really fix. Here are your psychotherapy guidelines from the VA that are the most recent from 2023. And keep in mind the VA has a specific patient population that they're focused on with trauma, right? So that may combat trauma may be very different than developmental trauma from another client in your office. So keep in mind that these are our best guidelines that we have in the United States because they're the leader on really understanding trauma, but they have a specific patient population that they're working with. So their recommendations are cognitive processing therapy, EMDR, which is one of those types of somatic therapies, prolonged exposure therapy. What we don't want to do is to just do talk therapy. And that's the majority of what clients out in our communities get. If they are going to a therapist, they may not be getting some sort of specialized trauma therapy. They're getting talk therapy. And what can happen with talk therapy is reimagining traumas over and over again, or inadvertently throwing them into that fight or flight response just because they're talking about it. And that doesn't really get us anywhere. So we want to be cautious. If you're talking about it in your sessions in your appointments with clients, just be cautious that you could trigger someone into that type of response. So screen, ask open-ended questions about how they're feeling, but we don't have to go directly into the trauma. And in fact, trauma therapy is not recalling the specific memories or events of the trauma. It's helping the body normalize and feel safe before we actually even process any of that in the future. And medication-wise, so we were all across the board in terms of which medications we wanted to use. And like I said, I use a lot of these different medications. But paroxetine, sertraline, and venlafaxine are evidence-based for this specific condition. Now, you may use some other modalities. Now, look, between 2017 and 2023, we had limiting antidepressants. We actually lost some of them. And I think that just speaks to the overall developmental trauma that our society is experiencing. Again, not all meds are going to respond as well to some of these folks. But you may, if you are trying sertraline, paroxetine, or venlafaxine, and you're not getting your bang for your buck, you may have to then go to some other options and treat symptoms, whether that be alpha blockers for that fight or flight response that we're experiencing maybe multiple times a day, or maybe some sort of sleep agent. I try to avoid the Z drugs with this patient population because, again, we don't want to shut things down completely, and we don't want to also increase the likelihood for someone to become addicted to a drug or get some sort of tolerance to it. Because once something works and they're feeling like it's the perfect drug for them, something that has to eventually be tapered off is a nightmare to do with someone with a complex PTSD. And to not necessarily rely solely on medications. So we don't have access to a lot of psychotherapies in our communities, but these types of clients should be getting some sort of psychotherapy. Here's some emerging treatments that may be of interest to you. So brexpiprazole and sertraline in combination. There's some phase 3 clinical data out there. And in fact, they're applying for a new indication for PTSD. So be aware of that in the future. Brexpiprazole has a specific component that also can help with that fear response. And so their phase 3 clinical data, as shown here, was pretty consistent with what I've seen in the community in treating PTSD. Is may also be helpful for some transient paranoia. And psychedelics. Now I'm sitting here in Pennsylvania and I'm wondering how many, I'm from Denver, so that's like a rhetoric to us. Psychedelics are just embedded in our culture in Denver. But I know that depending on the state that I go to, it's a taboo thing to talk about. So there is actually some data around certain psychedelics. And I'm not saying all psychedelics are good for trauma. And in fact, those psychedelic molecules do need to be used with much discretion and therapeutic support. So I don't reinforce that it should be used out in the community without any guidance, because it can go wrong, very wrong, if not used in the right modality and therapeutic support. But MDMA was recently sent into the FDA as a breakthrough therapy, and they did apply for PTSD. Now, it did get declined in August, but I will say that To replicate studies with a placebo-controlled trial, as we traditionally do for medications, is difficult with psychedelics, right? So usually your placebo group knows that they have not gotten the psychedelic. So it's really hard to replicate those studies, but they did have some positive studies. I do think it's the start of potentially some new molecules and compounds being created. And it's the concept of psychedelics is that you can slightly dissolve that default mode network enough to take away the fear response so that you can see yourself from a different perspective and potentially process or experience events without that fear response and learn new things throughout that process. So that's what psychedelics are focused on. And I think it's kind of a unique thing in psychiatry that we'll maybe see more of in the future. But when it comes to treating someone in a very short time frame, over a long period of time in a primary care setting, it's easy to add and add and add and add. And these are your clients, and they come into my office too saying, this isn't working. Now this isn't working. Can we try this? Can I try this? I researched this. Can we try that? So it's really common to have some polypharmacy show up here. And if you're treating symptoms, you may have to have an agent for anxiety and an agent for sleep and an agent for mood. So keep in mind that we want to minimize polypharmacy as much as possible. And going back to that, creating the balance, that sweet spot. We don't want to over-medicate and we don't want to under-medicate. So how can we do this without adding some polypharmacy? In fact, across the United States and then even in the world, there was a survey done that asked, what are your go-tos for PTSD? How are you managing this? How many medications are you using? There were no guidelines. There were no baseline opinions, and everyone had differing opinions throughout the world around how it should be treated. So it's a complex disease, and it's easy for us to just keep adding things in, but we want to make sure that we are utilizing therapy first, psychotherapy, your SSRIs, sertraline, paroxetine, and venlafaxine, and then you can add in some agents to manage certain symptoms, knowing that we don't want to just have a whole bucket full of meds, right? And these are people that want to find a cure, and so it's easy for us to want to say, give me a pill to fix it. It's really hard to do the actual trauma work that it takes to feel like you're surviving and thriving after trauma. So some patient education and treatment options that you may incorporate is really having as a baseline that non-judgmental, empathetic approach. We don't want to go directly into trauma, but we want to elicit enough information to let them know that you're a safe person to talk about it. And you can really weigh out the pros and cons with them. So I like to think of myself as an advanced practice nurse, that I'm here as your guide. I'm going to show you all the evidence-based treatments, and we get to decide together, as opposed to me saying, you need to do it this way. More agency that you can give clients with developmental trauma, the more power that they will feel to start taking their life back. And so we want to give them some options to make choices. My clients coming out of prison, I give them 2 to 3 options each time. I don't give them exhaustive options, but 2 to 3 so that they can focus on that. And it's little things. We want to provide agency to our clients to really feel confident again in making decisions, because many times that developmental trauma, that's been taken away. So offering some trauma-focused psychotherapy interventions. If you have some resources in your community, find a good trauma therapist that you can refer your clients to. It is like weight in gold and will save you so much time and effort if you can have a relationship with a good therapist to refer clients to in the community. And then you're going to be constantly monitoring symptoms, knowing that this is a progressive, up and down, relapse remitting type condition. You may have periods of time where it gets lots better, and then other times where they're going to struggle. So what are your specialty options to add in when areas of struggle come up. And knowing that substance abuse is so deeply embedded in how we deal with trauma, we need to be addressing the substance abuse as well. So some barriers. A lot of clients feel they're hopeless. Nobody understands me. Nobody gets it to the point where I don't feel heard in this healthcare system. Well, that cynicism is probably common, but how can we introduce some new ideas to clients to offer hope? So I like to say that my role is to be the hope builder. I'm here to just help build you up and kind of be your cheerleader. And you don't have to show up any certain way in my office. However you want to show up is fine with me, but I'm always going to maintain hope for you. That long term makes a difference, helps with that bias in care. And in terms of their symptoms, normalizing them. I go back to the sympathetic nervous response. Your body has been adapted to react this way. You're not choosing to have these symptoms, but we need to get your body back into choosing a normal homeoadaptive response. So let's work on helping your nervous system get re-regulated. And if I just use those in the medical terms, it takes away that shame and blame of I caused this. And oftentimes people with complex PTSD feel that they are bad, that they've caused their symptoms, that nothing's going to get better. So really being able to provide that hope is important. And educating them what could happen if we don't treat this. You know, you're using your motivational interviewing skills to navigate those conversations. So as I mentioned, your initial treatment options can include looking at the symptoms, referring to psychotherapy, and if that's not working, then you can refer to a psychiatric specialist. Okay, so looking at their patient preferences, having a warm handoff with whoever you're sending the referral to, I think is important too. And reminder that this is a collaborative care effort. So I'm working with my client to come up with some tools and resources for them to use. So here's some takeaways. You know, we want to screen. If you can screen for symptoms and potentially events, you'll have better understanding of your client. Even if you don't choose to treat the PTSD at all, you will be able to navigate medical care much better if you understand what's going on in the background. You can start treating this yourself by utilizing a few antidepressants and or other agents to manage the symptoms. And if you don't feel comfortable beyond that, or if the client is having some challenges in their functioning, even beyond psychotherapy and the initial treatment recommendations, it is okay to refer out. There are no guidelines saying, here's exactly when you can refer out. So it's up to your comfort level, your ability to have that conversation with the client, and your resources out in the community. So now that we have finished everything, I'd like us to vote again. We have a couple things that we reviewed, and hopefully I didn't nail it into your head too much, but we can go straight to the post-test questions. So let's see if we've improved from this. So this is the PC-PTSD screening. Who would we give this to? Which of the following patients are appropriate? So is this anyone who's experienced a traumatic event to themselves, A. Any patient who's been physically present or witness to a traumatic event either to themselves or others, B. C, any patient who's experienced or witnessed a traumatic event to themselves or others, including learning of an event from a loved one. And D, every patient in primary care should have a comprehensive screening, whether they report trauma or not. So this kind of goes back to our DSM definition of PTSD. Go ahead and vote. All right, the answer here is C. Okay, so I'm glad that I've encouraged you all to screen appropriately. So yes, it is okay to screen anyone you want, but technically, if you want to identify the folks who may be more prone to trauma and PTSD, and that could be the definition of either themselves, others, or witnessing it, learning about it through a loved one. And that would be C. All right, you guys better get this one right. Which antidepressants are recommended to treat PTSD based on 2023 VA guidelines? Is it A, sertraline, fluoxetine, and escitalopram? B, sertraline, paroxetine, and mirtazapine? C, sertraline, paroxetine, and venlafaxine? Or D, sertraline, escitalopram, and venlafaxine? Thanks for voting this morning. All right, great. Look at that post-test, you guys. We learned something. You went from 9% to 83%. Way to go. Okay. All right. Post-test 3. That's hard to read. Okay. Which of the following individuals who have reported experiencing trauma would be a priority referral to a specialist in psychiatric care? So is it an individual who has anxieties, coping well with stress through lifestyle changes? B, a person with a recent diagnosis of PTSD who's had a few therapy sessions and is showing some improvement in managing their symptoms? C, an individual experiencing persistent PTSD symptoms that are causing impairment in daily functioning and have not responded to initial treatment efforts? And D, a person with a long history of depression who's currently stable on medication and participating in therapy. One is not like the others. All right, thanks for voting. Great. So this one, we had a little bit less of a gap, but definitely someone who's having that persistent difficulty in managing their symptoms, and you've tried some things and it's just not working. And they're also in some psychotherapy. So thank you so much for having me here today to talk to you about this, because it's really something I'm passionate about. And I know that with the right tools and interest and motivation, you guys can treat a significant amount of trauma in the community. So I thank you guys for what you're doing and how we can all connect and kind of coordinate care together. With that, I think I'll turn it over to see if we have any questions.
I think we have some good questions
Okay.
coming in. We have some good questions.
Okay. Okay.
All right, there are some excellent ones. We have a little bit of time here. So I think the first one that's pretty interesting is you talked a lot about combining counseling with medication and how important that is. How do you approach the patient who doesn't want to do the counseling but is okay with the meds?
That's every patient out there, right? So that's a difficult one, because I think it just speaks to where we're at in society too. I mean, we want a pill to fix something. And unfortunately, PTSD does not have a pill to fix something. It may alleviate symptoms. And so what the education that I give is normalizing that this condition is not treated by just medication. And in fact, the gold standard is to giving some good therapy first. And we can manage symptoms. We're going to manage them. I talk about that sweet spot all the time. And I'll let clients know, especially those who have tried things. I'm even using lots of medications to manage their PTSD and nothing's working. I really go back to the body needs the psychotherapy in order for the meds to work well. It's just not going to work long-term with just a pill. And so I think having those discussions, and you can be direct about it. Oftentimes when I have that conversation, there's some acceptance and understanding, like, okay, we know that this isn't like fixable. It's not treatable for everything to just take a pill. And I think it's on us to have that conversation.
Yeah, I think a lot of it comes back to the education
Right.
and just normalizing things.
Right.
Can you talk a little bit about screening for PTSD in children as opposed to adults?
Yeah, so it's hard because you're watching potentially developmental trauma as it's occurring. And so you can use this screener, but it's not going to be evidence-based for children. Um, there's not really an evidence-based screener for kids, but you can start by having conversations utilizing the ACEs, I think, is another great screener so you can pick up on some developmental trauma as it's happening.
You talked a little bit about a lot of these complex PTSD patients can be misdiagnosed as other things.
Yes.
I know this is not an easy question, nor is there an easy answer, but a lot of bipolar patients are probably misdiagnosed. Is there some way to kind of tip us off if we're in a primary care setting to say,
Yeah.
oh, we should think more about this?
Yes, actually. This is a plug for screening well for bipolar disorder. There's a new screener out there that was developed in the last few years called the Rapid Mood Screener. It is much easier to use than an MDQ if you have been screening for bipolar with a screener with MDQ in the past. The Rapid Mood Screener is online, it's free. It's 6 questions, guys, and it has a high sensitivity and specificity for bipolar disorder and teasing out PTSD and borderline personality disorder. So one of the differentiators with bipolar disorder is you have distinct episodes in your lifetime where you have depression or mania or kind of like a hypomania. But most of the time with complex PTSD, this is chronic.
Mhm.
So you don't have distinct episodes. It's just kind of like this all the time. And so you want to do a screener to understand kind of the big picture of what someone's traumas may have been in their lifetime, developmental traumas, to get an idea of, is this just someone who's in chronic state of hypervigilance and anxiety, or is it someone who's experiencing maybe distinct episodes that are being caused by certain events? And guess what? You can have both. And there are clients that have both.
Yeah, that's a rough one. But I think that's super helpful, especially that it's free and we can access it
Yes.
online. So that's super helpful. You were one more question. I think this is actually a really good one, came from one of our virtual folks. Is this like a lifelong treatment? Are we treating forever? Is there, I'm sure people say like, oh, when am I going to get off this medication?
Yeah.
Is it something that we should set up long-term expectations with our patients?
That's a great question. And shout out to our online folks. Thank you for the question. So it depends. It depends on the individual. I believe, and I treat trauma as a specialty in psychiatry, it can get better. You can really resolve trauma and trauma response and feel better. Does that mean that it will go away forever? Sometimes not. And so you need to have an awareness that this could be a long-term trajectory. And it also can be difficult to assess whether or not that's going to be a long-term issue or not, because it all depends on the treatment that they get. And if we aren't giving the right treatment, the right psychotherapy, these clients are going to be stuck in PTSD for their life. I guarantee you, if they're not getting the right treatment, it will be a learned response that will stick with them for the rest of their lives. But it is absolutely possible to heal from this. And there are some, it's not an evidence-based screener tool, but there is I'll have to share this with the audience afterwards. I'm trying to think of the name of the screener, but it's trauma something inventory. It can show progress in symptoms. So you can actually track symptoms, and you should track symptoms over time, because you can have it get better. And we want to celebrate that progress and have the client also understand, oftentimes when they're sitting in it all day long, they don't recognize the progress that they've made in symptoms. So you want to track that and be able to help them regulate and see that this can get better.
Yeah, that sounds like an awesome way to get buy-in from them,
Mm-hmm.
To become compliant with the treatment and
Right.
do the counseling, do the medication. So that's awesome. We had some great questions. I'm sorry we can't get to everything. Shout out to the virtual people again. I just want to thank you, Chelsea. This was really awesome. I think it's super
Thank
helpful
you.
for all of us in primary.
Great.
Thank
Thanks
you.
so much, you guys.
Two Tracy's up here. It might get confusing. She's an infectious disease specialist at UCI Health in Los Alamitos, California. She's going to talk to us about Across the Divide, optimal approaches for HPV vaccination among diverse populations.
Good morning, Pennsylvania. How are you guys? Oh, I forgot I have a mic on. I have no disclosures. And our learning objectives are to recognize the burden of HPV-related diseases for patients and the healthcare system and the potential HPV vaccination to reduce that burden. We're going to integrate appropriate HPV vaccine messaging in clinical encounters with adolescents and young adults to increase vaccine uptake. And we're also going to identify barriers to timely HPV vaccination in key patient cohorts, including males, older adults, older adolescents, and underserved populations.
So we're going to start off with some questions, which is commonly what we do here. So for those of you providing patient care, how many adolescents and young adults do you provide care for in a typical week? A, 1 through 5, B, 6 through 10, C, 11 to 25, D, 26 to 50, E, greater than 50, or F, not applicable. I'm not doing this. All right, we're doing an okay amount, but looks like most of us are treating the adults. So, okay. Oops. All right, if following the CDC and ACIP recommendations, is a 24-year-old male patient indicated for HPV vaccination? A, nope, males are not indicated for routine vaccination, but not catch-up vaccination. No, catch-up vaccination is only indicated through age 21. Yes, catch-up vaccination is indicated if he tests negative for HPV. Or D, yes, catch-up vaccination is indicated. Do your best with this one. I'm appreciating the music. Oh, good job. We're going to learn some stuff today. Question 2, in a survey of women who have sex with women aged 18 to 45 years old who were not yet vaccinated with HPV vaccine, the most common reason for not being vaccinated was A, not receiving a healthcare provider recommendation to get the vaccine, B, perception of being low risk for acquiring HPV due to only having sex with women, C, perception of being too old to receive the vaccine, or D, not knowing enough about the vaccine to make an informed decision. Good job. Number 3, rate your agreement. I discussed the importance of HPV vaccination as a cancer prevention method at adolescent and young adult health maintenance visits. A, you strongly You strongly disagree. Sorry. B, you disagree. C, neutral. D, agree. Or E, strongly agree. I'm so proud of everybody here.
So we're going to start this talk about the underestimated burden and delayed manifestations of HPV. HPV infection is common among men and women. In the US, HPV causes about 37,000 cancers each year. The most common in women is cervical cancer, and in men, oropharyngeal. And in cervical cancer screening, HPV is the only test that it's validated for. Annual rates of HPV-associated cancers, if we look at women, typically starting in their 50s with cervical cancer, and then in their 60s followed by anal cancer, vulval cancer, and vaginal cancer. In men, starting a little bit later in their 60s with oropharyngeal, penile, and anal cancers. So how can we prevent cervical cancer? Well, 80 to 90% of new infections naturally regress in about 2 years, but about 10 to 20% of infections persist, and those can lead to, those high-risk HPV serotypes can lead to cancer development. So what can we do? Well, we can start with HPV vaccine and starting early to prevent cancer. The 9-valent HPV vaccine covers about 5% of those that cause cancer. And then after starting with vaccine, we have the option to screen and treat, and then we don't want to get to the point where we're at step 3, which is just treating cervical cancer without trying to start with prevention. The CDC and ACIP vaccine recommendations are for age 11 and 12, male and female, and it's a 2-dose vaccine. It's giving at day 0, and then the second dose is about, can be 6 months or 6 to 12 months later. The catch-up vaccine is for those age 13 and 14, and that's a 2-dose regimen. And for those above 15 to 26, that's a 3-dose vaccine. And then in those age 27 to 45, it's shared clinical decision-making. It is important to know that no HPV screening is necessary prior to vaccination at any age, and that 11 to 12 years was really the recommended because it coincided with well visits, but can be given as early as age 9. And we emphasize that this vaccination only works before infection has occurred. So the earlier, the better.
So we threw in a little question for you. If you're following the CDC and ACIP recommendations, is a 24-year-old male patient indicated for HPV vaccination? See if you're paying attention. A, nope, males are indicated for routine vaccination, but not catch-up vaccination. No, catch-up vaccination is only indicated through age 21. C, yes, catch-up vaccination is indicated if he tests negative for HPV. Or D, yes, catch-up vaccination is indicated.
So I'm going to kind of jump, since this is our post-test vaccination question, and we did really well. So we went from a pre-test of 72 to 82, and yes, vaccination is indicated. This gentleman is 24, so he meets the criteria up to age 26, and it would be a 3-dose regimen. So let's look at efficacy in HPV-related cancer. So this was an interesting population study of Finnish adolescent women who either received HPV vaccine, a control vaccine, or no vaccine. And then they were followed for 11 years. And the group that was vaccinated had 0 cancers. And you can see that in that 11-year progress of this adolescent group, there were cancers in the non-vaccinated group, from cervical cancer, tongue, vaginal, and vulvar cancers. This was a study looking at the 4-year efficacy after the 3-dose 9-valent vaccine. And this really showed that you had disease reduction, but it depended on your HPV serotype at baseline. Now, this is women. So some of the women who got this vaccine as adults already had HPV exposure. So if they got the vaccine and they had not previously had a serotype, they had significant risk reduction. And this is a 5-year immunogenicity after the 3-dose, just showing that really antibody response stayed pretty significant for 5 years. This is a really interesting study, and I'd like to emphasize it because it was a worldwide HPV vaccination study looking at implementing vaccine and then looking at cervical cancer incidence. It was done 64 countries, 4 subnational countries, 12 territories, implementing an HPV vaccination program. Of the 118 million women who were targeted for these programs, only 1% of those were from a low-income country or a low-middle-income country. And if you look at this slide on the right, the lower middle income and the low income comprise 56% of the cervical cancers worldwide. So this study really showed health inequality and that we need to do better at HPV vaccination programs in these countries. This was an interesting study in Costa Rica with an HPV vaccine trial. It was about 7,000 women who either received the vaccine or the control, which as an ID doc, I was very excited because they gave the Hep A vaccine, which is just awesome, better than placebo, because now they're protected for Hep A as well. And this looked at long-term follow-up over 11 years, and those who progressed to CIN3, they were due to non-vaccine HPV. So we know the vaccine, even though it was only a 2-valent that they received, protected them, and that anyone who developed CIN3, it was non-vaccine serotypes.
More questions.
Let's see, do we have them on yours? I don't see them on mine. Oops.
Oh, just a minute. I don't have any. Haven't seen any. We can keep going.
Okay, we'll keep going. So,
Don't see anybody asking any questions.
all right. So now we're going to talk about HPV vaccines in adolescents and young adults, and looking at 13 to 17-year-olds in the United States. And this is just coverage of females getting vaccine. And as you can see, we're not doing a good job. This is all adolescents, male and female, and we're still not doing a good job. So what's the hesitancy? So there's uncertainty, there's indecision, there's conflict, there's opposition. So how can we get past this? So as healthcare professionals, we need to be more knowledgeable, hence lectures like this. We need to educate ourselves and update ourselves. So some of the barriers for us is that we don't have the knowledge or that we lack the confidence to make the recommendations. We sometimes assume patient risk if something's going to go wrong or somebody's going to point a finger at us, inadequate reimbursements, and parental attitudes and concerns. So what can we do? We can build a trusting relationship. We can help modify the behavior. We need to be motivated. We need to be passionate. We need to be welcoming to questions, and we need to be patient. What are the barriers for the parents or the guardians? a lot of it is insufficient knowledge or downright misinformation, which, as we all know in healthcare, that has been significantly on the rise before COVID and then exacerbated during COVID. Parents and guardians also have a perceived lack of risk or benefit. My kid doesn't need it. You know, he's not sexually active or she's not sexually active. There are concerns about safety and efficacy, social influences, cultural stigma, or sexual behavior. Cost and insurance always comes up. Absent or inconsistent healthcare recommendations. And let's be honest, the impact of the COVID-19 pandemic, we are down in all vaccines across the board. So this just adds into the issue across the country with people not being up to date on vaccines. So the top 10 parental reasons for not vaccinating their teens, this was a study pre-COVID, and safety concerns, which were number one. They didn't think their child needed it, and then lack of recommendation by healthcare providers. So we have a lot of education we can do in here. So what's the barrier for the adolescents and teens? They don't know that they're at risk, or they don't know the benefit of prevention in the future. They have needle phobia. I have 2 teenage boys. I hear about this from their friends all the time. I have more than once gone with friends of theirs to get their vaccines and hold their hands. Infrequent healthcare visits, consent and confidentiality issues for adolescents. Some of them want the vaccine but don't want to have the discussion with their parents. So adolescent consent for HPV vaccination, 8 states and Washington, D.C. allow adolescents to consent by themselves. In all other states, adolescents can consent at age 18. So just a reminder, HPV vaccine is recommended up to age 26 by ACIP and CDC, but it is available to all of those up to age 45. So the barriers to HPV vaccination. For ourselves, it's our own knowledge gaps, financial concerns for our practices, and really addressing parental attitudes and concerns. For the parents and caregivers, again, lack of knowledge, which we have a gift to be able to now educate them, concerns about the vaccine itself, concerns that their child's sexual behavior will change after they're given a vaccine. And this has been studied before with birth control as well, and this really is not validated. It is not like, yay, I got my HPV vaccine, I'm gonna go out and go crazy. Same thing with birth control. It's just never been proven. It's just this kind of myth in people's mind. I think really the low perceived risk of HPV infection it's pretty common, and I think it's our job to educate how common it really is. The vaccine hesitancies, again, some racial and ethnic groups have some hesitancies. There's some cultural attitudes that have distrust in healthcare, language barriers, that comes up as well. Lack of transportation to come for the 2nd or 3rd vaccine. These are all real issues. So we should start the conversation early, because we can give this as early as age 9. Like I said, it's recommended between ages 11 and 12, but that was really because that's when a well check in the pediatrician's office is most common. We need to decrease the stigma and kind of focus on this being a cancer prevention vaccine and not an STD vaccine. Giving it early allows us to give 2 doses instead of 3. That's why my boys got it early, because they didn't want a 3rd dose. It is a greater opportunity to complete the actual series. And then we have the opportunity to increase immunogenicity by giving it early. This is a study, it was kind of teased out of the Costa Rica vaccine trial, and it actually looked at 1 dose of the 2-valent HPV vaccine, and it had similar efficacy to the second and third, to the 2 and 3 dose series over 7 years. So this is promising that maybe even just getting 1 dose in them will have some protection. There are further studies to see, will we be able to at some point recommend just a 1 dose? We are not there yet, but getting at least 1 dose in is better than no dose. We need to normalize HPV vaccination, recommend it the same way we do our MMR and our flu and our DTaps and all our other vaccines that we do, and just kind of add it in and don't tweeze it, separate it out as a separate vaccine. We need to emphasize the benefits and that they outweigh the risks. So how can we increase vaccination rates? We should recommend it for all adolescents, all at the same time as other vaccines. We need to ensure a consistent messaging about the vaccine, not only in ourselves as healthcare providers, but in our staff, because we all know it's very common that people chit-chat in the front. And if your front desk person is saying, oh, no, I'm not into that, that will really kind of derail the message for our office and clinics. We need to check patient immunization status at each visit to see whether, oh, we missed this. Let's kind of get it in now. We can share personal experiences. I'm always throwing my kids under the bus and sharing experiences all the time. And they had no problems, and I had an open discussion when they were vaccinated at age 11 and their options. And I'm like, you can wait, but then it's 3 doses. And then when I explained it, at least to my boys, about it being a cancer prevention vaccine, their honest response was, who wouldn't get this? So I think those conversations are really important. And just be prepared to answer parents and patients' questions and be, consistent and empathetic. Even though we're all rushed and pressured and stressed in medicine, we just really need to take the time to answer the questions. Do we have any questions yet?
I'm looking, I'm not seeing any. I think everybody's understanding well.
I have one here that I can see. I don't
Go
know if you
ahead.
can see it, or I don't know if we're saving it for a later, but because the HPV multi-dose vaccine, what strategies do you recommend for those who don't come back? What is the maximum time between doses? So if you're on a 2-dose regimen, it's the repeat dose can be anywhere from 6 to 12 months later. If you're on the 3-dose regimen, it's 1 to 2 months later, and then 6 months from the first. So it's like 0, 1 to 2, and 6 months. Again, those are the recommended, but if someone comes in and it's out of that time range, it is thought to be understood to just okay to give the vaccine and not have to start over in the series.
It's a good question.
So let's talk about our underserved populations and how we can do better messaging and get to them. So we'll start with our young adults. And although immunizations for HPV rates are increasing among men, they are significantly behind women. We're at like 9%. It's really sad. And why is this? Actually, I will get to why that is in a second. But actually, interestingly, this was a study looking at adolescents and young men and looking at HPV-related lesions, so warts. And they looked in, and when they vaccinated the adolescents versus young adult males, they had lower incidence of external genital warts and physical warts. And this was really significant because this can be, embarrassing, it can be shameful. And so vaccinating at a younger age actually helped prevent this, which was great. So now, why are males so behind females? And one of the reasons is that vaccination wasn't recommended for guys until 2011. And then at first, it was only a catch-up vaccine for those through age 21. And then it changed recently to be through age 26. So I kind of feel like it's just hard for physicians and healthcare providers to kind of stay up to date with this. Healthcare providers who encouraged consistent messaging and recommendations really helped the uptake of vaccination in the guys. They just need to be educated. So in adults, male and female, it's a 3-dose recommendation. If they're unvaccinated, it's 3 doses, like I said, day 0, day 1 to 2 months, and then 6 months. No HPV screening is necessary. This sometimes gets confusing. Some people think they need to do screening before giving it to it. And then in the adults age 27 to 45, this is shared decision making. So this is available for those 27 to 45. And how do we decide the shared decision making? Basically, anyone that has a new sexual partner, whether it's one partner or 20 partners or whatever, in my opinion, this person qualifies for HPV vaccine. Just a reminder that the vaccine does not prevent progression of HPV infection in the serotypes they already have. So if they already have a baseline serotype and they get a vaccine later in life, it will not stop the progression of the one that was prior to vaccine. So we're going to talk about LGBTQ. And this is awareness of gay men and bisexual men, and the awareness about HPV infection is really increasing, and we're getting our word out. But unfortunately, the awareness regarding vaccine is still not there. So we still have a ways to go. We're doing better with our educating that HPV is a problem, but we need to get out that vaccination is available and hit this target group. And this was a self-reported vaccine status in about 1,400 participants in a couple of big cities. And a little more than 22% reported completing a 3-dose HPV vaccine series. The median age for their first dose was 19. And 3/4 of them had already had their first sexual encounter. So really, it's good we've got them vaccinated. We're protecting them against serotypes that they may not already have. But again, just re-emphasizing the younger, the better before they're exposed. And education and recommendation went a long way in this group of really going ahead and getting vaccinated. This study was a survey in women who have sex with women. And it was about 500 women, and the drivers for not being vaccinated, the #1 driver was lack of recommendation by a healthcare provider. They didn't know they were supposed to get vaccinated. Some of them said, oh, I only have one partner, I'm not at risk, or I didn't even know about the vaccine. So really our word and our consistent measures of talking about the risk of HPV and vaccination available to them is quite important.
You guys are getting tested again. So in a survey of women who have sex with women aged 18 to 45 who were not yet vaccinated with the HPV vaccine, the most common reason for not getting the vaccination was A, not receiving an healthcare provider recommendation to get the vaccine, B, perception of being at low risk for acquiring HPV due to only having sex with women, C, perception of being too old to receive the vaccine, or D, not knowing enough about the vaccine to make an informed decision. Oh, everybody did stellar there. Look at those numbers.
We went from 16% to 74. That means like you guys are awake and the coffee kicked in and the music's helping. So that's great. So really this is important that we can make a difference, and really making the recommendation will go a long way. So let's talk about those who are high risk with HIV. This is an interesting study because it was done in really high-risk patients. Not only did they have HIV, but they had high-grade intraepithelial lesions on anal biopsy. And the primary endpoint for this was vaccine efficacy against instant and persistent anal HPV infection. And the secondary endpoint was efficacy against oral HPV infection. And it really didn't do much for the primary endpoint. It didn't help for persistent infection. And in the oral, it was kind of like a maybe, they can't really make a decision. So in this high-risk population, unfortunately, this was not really helpful. But it did lead us also to how can we get coverage in the HIV group. And really it focuses with a bunch of other call to actions is education, overcoming misconceptions, and trying to get our word out on getting vaccine early in this patient population. So let's talk about rural communities. So this was interesting. This looked at HPV vaccine, at least 1 dose. So it wasn't even 2 dose. And it was significantly lower in non-metropolitan areas by 9%. And some of this was due to adolescents that live in rural areas are less likely to have a well child visit at age 11 to 12, which is interesting. And in areas of rural areas, but also southern states, adolescents and caregivers had a lower confidence in vaccines. This is all vaccines. And this has been pretty well studied since COVID. But the southern states really just have a lower vaccination of all routine childhood vaccinations, including COVID and including HPV. So again, this is an area where we really need to educate. So how can we improve in these rural communities? We need to start with encouraging that 11 to 12-year-old well child visit, make the recommendation to our patients, understanding the parents and guardians' concerns and addressing those, answering questions as best that we can, and being consistent with our messaging. So what are the barriers? Significant barriers are, education and recommendations by healthcare providers. It's a busy slide with lots of stuff, but when you simplify it, it's really our job as healthcare providers to really make the recommendation, but educate ourselves, but also educate our patients.
I'm ready to test you again. I think you're going to do great. So let's rate your agreement. After participating in this program, I plan to discuss the importance of HPV vaccination as cancer prevention method at adolescent and young adult health maintenance visits. A, strongly disagree. B, disagree. C, neutral. D, agree. E, strongly agree. I have very high hopes here. Fantastic.
So let's talk about the future of the vaccines. Time has allowed for us to estimate when a booster may be needed, although we don't know just yet, but the studies are underway. We're also looking at evaluation of a single dose vaccine, basically to expand coverage and improve equity. More companies are developing effective HPV vaccines, so there will be a sustainable supply to meet global demand. And further novel vaccines are in development, and if approved, will also expand the HPV type coverage. So the DCVMN is a developing countries vaccine manufacturers network. This provides 50% of the doses of vaccine procured by UNICEF globally. It has 15 members, have vaccine products that have been pre-qualified by the WHO, and 4 HPV vaccine products available. The Chinese manufacturers that work with DCVM are actively developing an additional 10 HPV vaccines that are 9-valent or more, and 6 out of 10 of these are already in phase 3 trials. So this is very promising. So our take-home points is that HPV exposure and infection is prevalent in males and females, that if HPV infection does persist, it can lead to many types of oropharyngeal or genitourinary cancers. HPV vaccine is effective at reducing the risk of HPV-related cancers, and that vaccination must be followed with ongoing screening and treatment if cancer is identified. Underserved populations must be a priority for vaccination, and those barriers need to be identified and mitigated in a patient-centered approach. So now, I must have spoken really fast, that we have so much time left for questions and answers.
We have good questions.
Okay, I'm coming.
Hang out. So I think one important thing that you talked a lot about was that population of 27 to 45-year-old people and it being an informed decision. So how do you go about that if you have someone over the age of, within that population, so over 27, that you're trying to decide whether a recommendation for HPV vaccination is going to be appropriate?
Am I using this? Can you guys hear me on both? Okay, I'm good. I got the thumbs up. So 27 to 45, actually, this is an interesting discussion because I'm above 45, but have had this conversation for years with friends, colleagues, etc. And basically, it's anybody who's having even one new sexual partner, whether married or not married, in a relationship, multiple relationships. And basically, it is not CDC ACIP, so sometimes they do have to pay out of pocket, but it really is recommended. An interesting conversation I had with one of my GYN colleagues the other day is there are actually some small studies right now looking at even above age 45 for those who have CIN 3 and above, vaccinating even above that. I am not advocating. There is just conversation about that already, and patients paying out of pocket. It's about $200 to $300 for the vaccine because they're trying to protect from any other serotypes and progression. So I think basically my low threshold is if you have one new sexual partner, go get vaccinated.
Yeah, that's good to know. And a lot of it, again, is just education and having that discussion with patients, I would suppose. Do you think that, I mean, universally, I think in most states, HPV isn't a required vaccination for school? Do you think that that has an influence on the uptake of vaccination rates with the adolescents?
Yeah, that's kind of a loaded question because I feel like it's very state dependent of what's mandatory for schools and not, and that may or may not change in the coming months. But yeah, I think some of it is that it's separated out from our MMR and our tetanus and our flu shots and everything else. And so because it's not mandatory, it's kind of treated differently. And I think our goal as healthcare professionals is really just to kind of lump it in with all our other vaccine recommendations, whether it's mandatory for school or not. And just, when you're, in the office and you're just like, oh, okay, you're due for your tetanus, your MMR, your HPV. Not
presenting it as normal.
right.
Do you find yourself or colleagues needing to do that a lot more and taking that approach maybe with parents of younger patients when you're talking about the 11 or 12-year-olds getting closer to the teenage years?
Yeah, I mean, I have this conversation for years. I have a 13 and 17-year-old. So I've been having this conversation with friends, colleagues, anyone that'll listen to me. Basically, just that this is a cancer prevention vaccine. And like, this is an amazing opportunity to give it now when they're kids, to prevent cancer when they're an adult. And that seems to resonate with people more than the lots of social media hype that was, oh, this is a STD vaccine, which is how it came out. And you have to remember, this vaccine has been used in Australia originally, way longer than before it was in the United States. And their cervical cancer rates, among other oropharyngeal and anal and so forth, have plummeted. And they have amazing data to show this. And that data was even before we were implementing it here in the US. And that data has been persistent in showing how low the cancer rates are. So for me, as a parent of teens and an ID doc who likes to be annoying, is really just pushing this as the cancer prevention vaccine. And I think kids get it. I think adults get it. And when you take the stigma of sexually transmitted out of it, it really changes the dialogue and conversation.
Yeah, that's a good point. Do you have different discussion points that you use when you're talking to females as opposed to males about getting the vaccine, or?
I'm an equal opportunity annoying human being when it comes to vaccine. Like I said, I have 2 boys, and I presented it very straightforward as a cancer vaccine for them. And, HPV infection is just everywhere, and, equal opportunity,
Right. What are the most common side effects you see with the vaccine itself? I know in the beginning, there was a lot of hype about different things happening. I know that swayed a lot of parents from not getting it right away for their kids.
I will tell you, the number one complaint is that their arm hurts like a tetanus shot. And so that is actually, I've heard it from kids and adult patients who are just like, oh, I feel like I was sucker punched. That was really it. That's the big major thing. Some people get some localized redness, but really not more than that.
That's awesome. So I think we covered a lot of really good questions. I want to thank the virtual people for being here too. I want to thank Tracy. Awesome to see you. Tracy and I know each other from New Jersey. So it's exciting.
We practice lots of clinical medicine together.
Yeah, so it's
great.
exciting to see her again. Before we break for lunch, we do have a couple of announcements. So you're going to have to listen to me a little bit more. So I want to remind you, please use the QR code on the tables because they are going to access the handouts so you can do the evaluations for all of the sessions. We want to make sure we do that. You want your CME and CE credits. Don't come here and not get credit for being here today. There's also a tab on your iPad, the iPad's here, for an attendance experience survey. So please do that because we want to really enhance these experiences and use your feedback so that we can, provide things that are important to you guys. Remember that there are exhibits outside. Please take advantage of that when you guys are looking for lunch and make sure that you go and talk to our exhibitors because it's, through that we get to do a lot of this. You can also come back here to eat. If you guys get your food and come back here. And remember to take your badges with you because you're going to have to rescan it for the next session because there's a compliance thing with that. When you come back from lunch, this is important. There's going to be a non-CME product theater that's going to be sponsored by Novo Nordisk. And it is entitled The Attention on MASH, the hepatic manifestation of the metabolic syndrome. And that's going to be presented by Dr. Gunn. And then we will reconvene promptly at 1:35 to begin our next session. And I think everybody can get some good lunch. Virtual people can take a break, and we'll see you all back here. Thanks so much. exciting. Yes, no, or unsure? I hope you're sure.